So thank you all for joining our 8th session in our CAHME Mentorship Circle series today. We're happy to have Johns Hopkins University discussing driving brand recognition and student enrollment, Johns Hopkins University's worldwide impact during COVID-19. My name is Melissa Cross, and I'm the Education Manager for CAHME. So just a little background. I know Beth is going to talk about this a little later in the session. So the idea behind why we're doing this today, Johns Hopkins scored number 8 on the Profit Brand Index this year. It scored well as a national and regional health provider that serves close to 5 million people, furthering the understanding of every user using the COVID-19 dashboard from public health experts to journalists to concerned citizens. And here to tell us about the remarkable work today and the story of how it all happened, we have a great group of panelists. I'm now going to pass it over to Beth, who will be facilitating the discussion amongst the team to best tell their story. Beth will have her team tell a little bit more about themselves and the role that they played within JHU and the COVID-19 data dashboard and the impact it has had on Johns Hopkins University. So Beth, I'm going to pass it over to you.
Thanks so much, Melissa. And just, well, thanks everyone for joining us today. I am very lucky to be hosting this panel with some of my most favorite colleagues who I am actually going to allow to introduce themselves to start. I'm Beth Blauer. I'm the Associate Vice Provost here at Johns Hopkins University over Public Sector Innovation. I'm also the Executive Director of the Centers for Civic Impact. And in our role at the centers, we have been the data leads for the Coronavirus Resource Center. So all the data visualizations associated with our tracking of COVID have been a contribution that our team has led. I'm going to hand it over to Mary, who's going to introduce herself, and then we're going to go through the whole panel so you can get a sense of who's here. And then we've got a great, exciting program. We're going to talk about the development of the tools and the impact that it's had on us from an institutional perspective. So Mary, if you could lead the way with an introduction.
Certainly. I am Mary Conway Vaughan. I'm the lead program coordinator at the Centers for Civic Impact and the project manager for the Coronavirus Resource Center. In that role, I weave together all of the disparate and different voices within the university and channel that into the web application and site that you see every day. So I have a background in project management going about, I would say 20 years or so in a variety of different enterprises, all the way from toy production through educational nonprofits through my work here at the Centers for Civic Impact. And I will say that I think it has taken all of those different environments to understand how to weave together all of the different efforts across the university. So with that, I will hand it over to Sarah.
Thank you, Mary. I'm Sarah. I'm the data scientist at the Centers for Civic Impact and the lead data scientist for the Coronavirus Resource Center. I have a PhD in astrophysics, which has definitely helped me lead all the decisions regarding data and data visualization for the Coronavirus Resource Center. And with that, I'm going to call Jennifer.
Hello, everyone. I'm Jennifer Nuzzo. I'm an associate professor at the Johns Hopkins Bloomberg School of Public Health. I have primary appointments in the Department of Environmental Health and Engineering. I have a joint in the Department of Epidemiology. I'm an epidemiologist by training. I'm also a senior scholar at Johns Hopkins Center for Health Security. And are we turning it to Mark next?
Yes.
Great.
Thanks, Jennifer. My name is Mark Biddle. I'm a senior scientist in the Department of Health Policy and Management in the Bloomberg School of Public Health. And I also have the honor and privilege to be the program director for 2 of our graduate programs in health administration, our Master's in Applied Science in Population Health Management, which is a rather new, fully online graduate degree, and our longstanding Master's in Health Administration program, which is CAHME accredited. And we, I think, have been the beneficiary this year of all the hard work that you're about to hear.
Great. So thank you so much. We have a very esteemed panel and we're very lucky. So I want to dive right in. I'm going to just make another plug reminder that we have the chat box open. So if there are questions you want us to cover, territory you want us to cover, if we go through any of this work and we pass by something that you would like us to go deeper in, really please take advantage of the chat box so that we can make sure that everyone gets the most out of the session. If you haven't already seen this map, this is our global dashboard. It is sort of what birthed us into this space where we are now, where we became essentially at Johns Hopkins University the sort of standard bearer for collecting and disseminating COVID-19 data. I want to start with a little bit of background about the global map, just so that everyone, so we can set the stage appropriately for this conversation. The map itself was started by a colleague who's not represented on the panel today because she's enjoying a parental leave in Hawaii, but Dr. Lauren Gardner, who was working with a graduate student on her team who had been tracking communicable diseases using GIS technology, so geographic information systems, where they had been tracking measles outbreaks and other communicable disease outbreaks and really looking at the intersection of our built environments in cities and the way that disease spreads within condensed or highly dense populations. And so she had actually a postdoctoral student, I believe, or a graduate student in her program that actually came from Wuhan, China, who was had family members in the region, and he said, "I'd really love to start to track this nascent disease that is affecting this region of the world that I come from." And they, of course, said, "Yeah, let's do it." And so it started off very much like a lot of their other data collections, where they started looking at all the publicly available data on the disease and just started plotting it on the map. At the same time, at the Centers for Civic Impact, we were about to do a bunch of international travel. And so we were trying to figure out what was happening with this disease and whether it was safe to send people into the field. And the only resource that was comprehensive enough to give us the insights that we needed to make those calls was actually being run in a building that was, less than 100 yards from where we were all sitting. And so we started to have a conversation with the team that was doing this initial data collection. And it became very evident a few things. One, we weren't going to be doing the international travel. Two, that there was a very rich data set that was being built, but that there was going to be a demand for it much broader than the research that had generally been the input for the work that Dr. Gardner and her team had done up until then. And so the university, through the leadership of the president's office, decided very purposefully to put together a cross-university team to start thinking about how we can not only just visualize this data, but pair this data with world-leading subject matter expertise to help guide the international community as they navigated this deadly virus. And so our team was a very organically built team that slowly grew over time as we started to really understand the dynamics of COVID and how COVID is going to be impacting communities, what the needs were from a data perspective, and how we would evolve our work together. And so what started with dots on a map turned into a very rich fabric or mosaic of data and visualizations, public health guidance, best practice setting, standard setting, and an ongoing high level a real understanding of not only the challenges of tracking such a complex disease, but also the challenge of having to navigate this disease with the only lever that we really had at our disposal, which was public policy. Are you going to wear a mask? Are you going to open businesses and schools? Are you going to be thinking about these difficult decisions in a landscape of evidence or using gut and intuition? And we saw very quickly that evidence was going to be at the center of a lot of this decision. And so I'm going to bring Mary in because she becomes sort of a material part of this story at this point where we know we have all this data. We know we need to marshal this data. We have this request from the president's office on we want to visualize this data, and we start to wrap our arms around the data. And I would like, Mary, if you could at this point, first of all, I think there's a couple other things we have to also acknowledge. The team at the CRC, the Coronavirus Resource Center, is entirely women-led. So our chief epidemiologist, Jennifer, is a woman. Our chief data scientist, Sarah, is a woman. Dr. Gardner is a woman who did all of our GIS work and really helped with the data architecture. And our lead data architect at the Applied Physics Lab is also a woman. So if I can make any plug, it's that we need more women in STEM because they do exceptional work when they get the opportunity. And then Mary came in, and Mary is at the center of all of this, right? So Mary really has kept us all together, kept us all organized. And Mary, talk a little bit about your experience and the kind of opportunity that you've had to kind of weave all of this together.
Certainly. So it all started with, I think it was a Slack message or something like that. Beth in March of last year said, hey, do you think you might have some capacity to help project manage some work with data visualizations around coronavirus? And I said, sure, why not? That sounds interesting. It will give me a chance to learn more about it. And that has been my life for the subsequent, I guess, 16 months or 14 months. So the work that I was invited into basically involved weaving together a variety of different organizations within and external to the university. So the Bloomberg School of Public Health, Johns Hopkins Department of Medicine, the Center for Systems Science and Engineering, the Centers for Civic Impact, the Center for Health Security. These entities all have a very strong voice in the Coronavirus Resource Center, but required traffic management to pull everyone together and to appropriately use their time. So it wasn't all hands on deck around the clock all of the time. It was figuring out ways of providing a routine cadence of meetings and appropriate communications channels to give everyone the opportunity to have voice in the project, but not pulling them completely, in hopefully most cases, completely away from their regular jobs, because we all had full-time employment prior to the Coronavirus Resource Center becoming a reality. So there were a few, at the outset, it was a bit of a round-the-clock effort the first 6 weeks or so, but that was what it takes to put together an infrastructure that is workable. And since then, we've maintained a collection of different meetings that pull together all of these brilliant minds to talk about what the trends are and how best to visualize them and how best to schedule things to be timely and to use the public health focus of the university and of the university medical system to put out timely, important information that we think is vital and valuable, not only to general users, to the general public, but also to policymakers, and also as a secondary source or a primary source for people who are checking data that's being reported through their own government entities within their county, city, state, and regional governments. So that is the large lift of effort that I put forth every day, but it is also trying to ensure that the documentation for what we're doing and the rationale and the decision making are all adhering to the overarching goal of the site, which is to provide public health and information in a digestible way so that you don't lose sight of the trends and you are able to very quickly, and you can see it on the screen in front of you, you can even at this zoomed out level detect trends and lines and concerns and things like that. And then when you're able to dig into the data a little more deeply, because we acknowledge that we do have public health experts who use this data as well, we give several different layers down where people can examine the data at a more granular level. So some of the complexity that has arisen from trying to pull all of this information together is more of a topic that Sarah will cover. But we use not only we not only leverage the expertise within the university itself, but we have to learn as we go, because what we're finding is that not everyone reports data in the same way, and not everybody uses the same definitions with the same words attached to them and things along those lines. So it really requires a deep level of expertise within our team to discern what other entities are reporting and pull it together in a cohesive way that we can then represent on our site. So that is a really broad strokes view of what it is that I do and the work of the site.
Yeah, and I just want to make sure that everyone understands the scale of the site itself. So the scale of the site itself, and Mary's done a good job at talking about the fact that, you know, she's been leading this. And I think it's one of the first examples of cross-university project management, where we've had a project manager who's been responsible for marshaling resources from both the Krieger School where we are, the School of Public Health where Jennifer sits, APL, which is an independent organization within the university, and then the School of Engineering. But to give you a sense of the scale, and this is a good segue into Sarah, we have all of the data that's available on the site is public. So you have all of this data that sits beneath these visualizations and this map, it's public. We get over 10 billion calls to that data a day. So those are API endpoints that are connecting into the back end of the map, that are being used for embedded into decision-making tools in large corporations, for what we call armchair epidemiologists building blogs and using the data in real time to update their own exploration of the information. We have billions of regular dependencies that have been built on the data. In addition to that, the CRC has had more than 1 billion views of our pages. So the pages where we have done our own analysis, we've got more than 1 billion people that have come to look and explore the information and the advice. And so what does that tell us? This is not just for research. This is not just for the media. This has been a resource that has been relied on for, whether my parents who are going to decide whether they're going to the grocery store or where they're going to wear a mask. Teachers have been using it in academic settings for students in K through 12 education. We know that it's powering research. So it's such a diverse and dynamic tool. And so, Sarah, I want to talk to you a little bit about how do you take very complex data and democratize it in a way that has been able to sort of capture the attention of this audience, and thinking about the fact that we've had, the visualizations that you see here thumbnailed in this slide. We've had partnerships with people like NPR who have been working on contact tracing data and trying to understand the role of contact tracing. We've used the data to accelerate our long-term view of the disease. Talk a little bit about the role of data science and the way that you have been able to sort of capture this audience and take them through. I don't think 2 years ago, my kids certainly would be able to tell you what flattening a curve meant, or like talk about sort of these statistical frameworks. And now those are really part of our regular jargon. And that's in large part to the fact that we were able to do this democratization through data visualization. So please, Sarah, take it away and talk us through a little bit about the opportunities, but also the challenges that you faced as a data scientist in this realm.
Thank you, Beth. So I would say one of the first challenges obviously is collect the data, but once you do that, you have the challenge of, given the lack of data standards and data definitions, the challenge that we are facing is that it's us who have the responsibility to organize the data, to homogenize in order to be able to compare one source to the next one. The data collection process, just to give you a quick overview, it's basically a series of steps that always start with manual data collection, identifying the most reliable sources, and also seeing it, looking also for alternative data sources, because, some of them have some maintenance, some of them break. It's a constant process of keeping data sources reliably to feed every day, every 30 minutes, this data. But once you have all this data together, you face the challenge that, this data that, somebody is calling this data point, for example, cases confirmed, is not exactly the same as the cases confirmed from this other different data source. So you have to put together a lot of time to create a logic to put all this data together in the best way so that you can compare them and show them all together in the page. Sometimes, you have to take different decisions on what you weight more, what you weight less, how are you going to treat this data just a tiny bit before showing it in the page. We try to do minimal data processing to show the data as raw as possible, but sometimes we have to filter, exclude dates, and so on. And that is a process that happens every day, every morning when we get the new data. And there is the challenge of, how am I going to visualize this? As Mary was saying before, it's a real challenge because you have so many different audiences checking these data visualizations. You have the general public, obviously, but you also have media. You also have experts in public health that rely on these data visualizations to, inform at different levels. So it's a real challenge. And I would say that first of all, one of the keys of the success is that in the process of creating these data visualizations, the team that reviews it is very diverse. So the feedback that we get at very different levels help build these visualizations so that the audience that can cover it's diverse at the same time. And also another key for the data visualizations is that, you know, any graph that you see on the web, it has to quickly provide a message just in the first seconds that you take a look to it. And then it also at the same time has to allow you to get deeper into the data and everything in the same view. So it's a bit of a challenge to get to that point, and it requires a lot of iterations, but it's a process that we create, you know, with each of them, there is a group of like maybe 30 people who review the visual before it goes live. And it starts with drafting, then creating, then going through subject matter experts, then through communications and so on. And also the bit of narrative that comes with the visual helps a lot. And there is a, you know, midpoint between, well, you have to create a bit of narrative, but not enough, not, you know, a ton, so it's overwhelming for the user who reads. So I think we have learned during these 14 months to, you know, create these visuals in a way that they are more useful for all the different audiences. And it has been a learning process, but I think we have been at the end very successful in creating that. Beth, I think you're muted.
Sorry about that. I agree. I think it also has been very successful. I was kind of cycling through some of those visualizations, Sarah, that you've led the team through. And I want to pivot a little bit. One of the, I think, most important elements of our work is that we are a team that's very focused on data and the science of using data to shape policy making. And we can't do that without subject matter expertise. I am not a public health expert, either are my colleagues, but except for Jennifer, who has been a material part of the work that we have done. And so very early on, we took this data and we started to pull in subject matter expertise from across the institution to make sure that not only were we being responsible in the way that we were depicting the data, but that the messaging that we were sending out to the public that was a compendium to the information was actually going to be able to inform policy. And one of the ways that we've done that is by comparing kind of the output of that work, which is like states did not have a ton of guidance on how to navigate these things. And so we became a very important part of the kind of array of supports that public institutions had to do this work. And that was all anchored by our subject matter experts, Jennifer being the chief among them. So Jennifer, I'd love for you to just talk a little bit about the role of subject matter expertise, the intersection of that subject matter expertise and the data, and the work that you've been so incredibly instructive on as we have really started to think about the breadth of how we can communicate with this data.
Thanks, Beth. Yeah, it's really been a privilege to be working with this team on this really, I think, critical resource. I still very much view myself as maybe a super user of the data. I do research in this space of pandemic preparedness and response, and also am very involved in sort of the policy elements of this. And so quite early on was asked to kind of weigh in on what was happening in the world. I testified at the first U.S. government congressional hearing on COVID. So to understand what was going on, I went looking for data, and it was very clear quite early that the Johns Hopkins site was the best place to get the data that I needed. I actually came to the team with a request for different analyses because I was trying to, tease apart the data in different ways and to understand some of the drivers and the case numbers and some of the kind of contextual factors, which as an epidemiologist, we tend to think about. And was fortunately at a time when they were just about to launch an effort to track COVID testing in the US. So back in the spring of 2020, if we can remember back then, testing was very limited, and it was a really important dimension of the response, whether the US was able to do enough testing to meet the demands. So I jumped at the chance to participate, in part because I was so reliant on the data myself, and was really thrilled to be part of this really amazing team that has been able to pull together, visualize, and make accessible, critically important data for decision making. So one of the things that we talked about early on was, it's not just important to gather data, but to just provide some level of analysis and to interpret it for decision makers. In the case of testing, it wasn't clear initially what the right dimension, metric to use to kind of track our testing progress. There was a lot of conversation about how many tests the United States was doing, but from the kind of public health epidemiologic standpoint, the number of tests wasn't really a meaningful indicator, because how many tests we have to do would vary by how many infections there are. So we settled on the site early on the idea of tracking test positivity. So the percentage of tests, or the percentage of people tested that comes back positive. We thought that was a metric that was more tied to the demands of the epidemic in the United States versus just an artificial number of numbers of tests performed. Positivity is probably something you've now heard of. It wasn't really a very well-known metric, at the onset, but it has since become one. And I think it's really helped us better understand, not only how the cases have been unfolding in the United States and internationally. We have an international visualization as well. But whether we are meeting our operational demands, whether we're doing enough to have the strength of the surveillance that we need, whether there are shortcomings, and we've seen challenges along the way. They haven't shown here, but if you check out the Biden COVID plan that was released just very at the start of the administration, or just prior to President Biden's swearing in, they have a test positivity graphic that looks very similar to this one, and it only exists on our site. So, I think it's clear that we have had impact in terms of shaping the conversation around testing. I still rely on these data daily. I continually look at it to try to understand what's happening. I get a lot of calls from media trying to understand. I walk them through the site. I show them the numbers. Even media outlets that have their own data tracking efforts, they still need experts to tell them what it all means, even if they have the data themselves. And so having our own data and understanding the limitations and what the data mean, I think has been really helpful to be able to continue to do that kind of communication work with media and others who are calling and asking for information about decisions that they have to make, or to try to understand the state of the world.
Thank you, Jennifer. And so in addition to Jennifer, we also have a vaccination expert that sits in our regular meetings. We have had people that come from the business school that have been helping us think through the kind of economic impact that COVID has had on communities. It's been a real a demonstration of the sort of one university moment that Hopkins has really catalyzed. That's really allowed us to draw in from experts, whether they're engineers, whether they're public health experts, whether they're medicine experts. I can do a little plug. We have a regular briefing on Fridays, and they are really a showcase of that expertise that we've been honing. And it's a mix, and it's hosted through the CRC, where we're able to bring in those voices from across the institution. I do want to also talk a little bit about the impact institutionally that this work has had on who we are and how we function as a university. Being part of this effort has, I think, really transformed a lot of our lives in terms of the way that we see our roles both at the university and also materially how we would like to sort of architect the next phase of our institutions. And so I can't imagine a world where I'm not partnering with Jennifer in perpetuity as we continue to navigate some of the other persistent challenges that communities face from a public health perspective, using data and really thinking about about the next phase post-pandemic, where we can continue to marshal these resources, because we realized very quickly that they don't exist anywhere else. And that had really helped us get to the point where we are now. I think Melissa mentioned this in the intro. One of the big markers of that was when Profit, which is sort of the standard bearer for brand recognition, said we were in their top 10 brands for the last year. That has really improved Johns Hopkins was no shrinking violet before the pandemic, but this certainly has had a significant impact on the institution, the institutional reputation, but also the interest in partnering with the institution, in joining the institution, and certainly learning within the institution. And so I want to talk a little bit with Mark, to you, about what you think have been the most important institutional impacts that this work around COVID has had, and where you think that that's going to help lead us in the future.
Great. Well, thanks, Beth. First of all, I just wanted to say how fortunate I am to be on the panel with such great experts in this field. It's been just fantastic to watch over the last 14, 16 months develop, and I'm just proud to be part of the Hopkins family at this point. So thank you, Beth and Jennifer and Mary and Sarah. I just got to put a plug out there for what you said, Beth, about women in STEM. My daughter's a PhD astrophysicist and a data scientist, so it's great to see the work that you all do, and it's fantastic. So I think it's interesting if you just look at some basic numbers this year. Typically I think universities see an uptick in enrollments during downtimes in the economy. It's kind of an inverse relationship. The economy gets bad, people go back to school and retool. But this year was interesting, I think, from the healthcare perspective. Given COVID, I think all the information that was out there about what great work the people in healthcare and public health have been doing around the COVID pandemic has just, I think, sparked a renewed interest in the field. And some of the numbers that we've seen just in the School of Public Health. Again, Hopkins, as Beth said, is no shrinking violet. We have the #1 school of public health, and we've seen our enrollments increase dramatically. Our average sort of, census every year is about 1,400 students. We're looking at about 1,600 students this year, so about a 28% increase in applications, a 30% increase in the students that we've admitted, and more importantly, a 40% increase in the acceptances across the School of Public Health. And that trickles down into our program. So I'm a healthcare administrator by training, and I run 2 health administration programs, and we've seen even more dramatic increases in our applications and enrollment. So just, to name a few, the MPH, the signature program in our School of Public Health, saw a 17% increase in applications, so about 714 just for the MPH program. And acceptances were almost 300, which was up about 50%. So we had a tremendous increase in the interest in our MPH program, Masters in Public Health. Our MHA program, we had 321 applicants, which was a 60% increase in our applications this year. Interestingly enough, I was working in healthcare administration during the economic downturn in 2008, 2009. For those of you in the industry know, during that period of time, healthcare was probably one of the few industries that were actually hiring people during the economic downturn. So we saw an influx of interest in people looking for jobs in healthcare. I think this time, hopefully, the interest level is being driven by what great work we do in that field. So again, our applications are up 60%. Our class size is the largest that we've ever admitted. We're a cohort model, so we have a fixed number of seats, but we're admitting 40 students this year, which is our biggest program size. We actually admitted fewer people this year, but we have more coming. And then our population health management program similarly had a 37% increase. It's a relatively new online program. We had 87 applications this year, which was up 37%. And our acceptances are up 40%. So we have currently 50 people coming to the program so far, and we haven't even closed the admission cycle yet. So I think one of the benefits of this has not only been the interest that it's drawn towards the university and in a broader way, public health and healthcare administration. I think for the students that ultimately wind up becoming part of Hopkins, it's just the access to wonderful experts like Beth and Jennifer and Sarah and Mary, that and all of our faculty in the various schools that really allow our students to get the most out of their public health and healthcare education. It's just having access to these experts and the scientific and the evidence basis behind what we do and how we teach and how we convey the various concepts, that this is really being driven by evidence, not just in what we're doing as you've seen here, but just in terms of what drives our curricular development, course development. It's really about using the best available evidence in meaningful ways to drive education forward.
Great, Mark, thank you so much. And that data is stunning. I'm a data person, and I can tell you that data is stunning. And I think that we're seeing that effect across the university. There's a lot of interest inbound across the university, across the schools, and we've enjoyed a lot of well-earned praise for the work. But I also think that I think it's a model that's going to enrich the student experience. We've been able to bring students, both graduate students and soon-to-be undergraduate students, into the work in ways where they get exposed to not only the data and to helping us sort of process the data and work with the data, but also that alignment to policymakers and to the kind of tough questions and the challenges. And they are unique challenges that are so highly relevant. And I think that we have a student body that's deeply interested in having immediate impact. And this is just a way to be able to realize some of that academic aspiration. And so it's been a real pleasure to start thinking about the role of this work and the intersection of this work with the student population. So it's great. And thank you. So now is the time where we're going to be able to turn it over to you and see if there are any questions. I know, Melissa, you've received some questions, but I really want to encourage some dialogue. We are going to lose Jennifer. She has to depart a little bit early. And so if there are anything immediate on the public health front, we should try to get that to Jennifer before she hops off. But that said, we would really like to open it up to more of a discussion. So Melissa, I'm going to hand it over to you to help us through a Q&A. And I also have some questions too. So please don't hesitate.
Okay, so something that was brought to me was they wanted to know how we're able to make connections within the media, like the news, the outlets, like you were talking about, all the coverage. I know you had mentioned that, you guys kind of beat everybody to the punch, so they kind of approached you because you were the only ones doing it. But did the media kind of approach you guys in that sense, or did you kind of bring it to them? Can you talk about a little bit how that relationship formed?
So one of the very first decisions that was made around the data resource was that it was going to be open. We were going to use an open license for the data, which would allow any user, and it was going to be automated. So we built an API on the backside, or we left it, we built an open access into the data. And CNN was the first outlet that started using the data, and it became a fixture. I mean, you can still today, if you tune into CNN, you'll see that they still are tracking COVID data on a regular basis, and it's credited back to Johns Hopkins University. That, I think, sort of gave birth to a lot of interest to using our data in the absence of that standard bearer. I think at first people were looking to the WHO, they were looking to the CDC, and both organizations were very slow to start thinking about marshaling data resources out to the public. And here we were already with an infrastructure built. It seemed to be reliable. It seemed to be easily able to vet. We were very public with where our sources were, and so we became a partner. So NPR and CNN were our first media partners. They both still heavily rely on our data. We actually extended the relationship with NPR, and they partnered with us on our contact tracing and data collection initiative. But a lot of it was organically generated press interest. We also did not hesitate to use this very vocal opportunity to do advocacy on the strengthening. So Jennifer has been out there talking about the deficit in data, the deficit in standardization. We together have been out there talking about it and had the opportunity to do a lot of writing. The New York Times published a series of op-eds where we talked about the real difficulties of navigating the disease in the absence of data standardization. I've been very vocal specifically around the lack of demographic granularity in the data and our ability to actually pinpoint resources. And I think that a lot of that has generated a bit of an organic attention. I will say we have a communications team. So we are not alone in this work. We rely on the university communications infrastructure quite heavily. One of the leaders of the CRC is a strategic comms person. And she is very good at telling us when we're overcomplicating data visualizations. And so, it's been a real joint initiative, and that continues to be a real source of, I think, some of the most material help that we've received from the university is making sure that we were effectively communicating our work.
Yeah. And being that you said the data was so open, I'm not directly involved with a lot, but I do work with a lot of the program directors. They see Nalan on here from SHU, and I know a lot of their case competitions were COVID-based this year, and they incorporate a lot of the JHU data. So having that data open, to everybody, I think was just beneficial for everybody, student projects, and everyone's just learning from you guys all around. So great work. And one other question, then I know we can get to your questions, Beth, was, so what's next? You've seen that JHU has been accepted as a critical and highly respected source of health data. Given your success with presenting COVID-19 statistics, where do you go from here?
I want Jennifer to quickly answer that from her perspective, and then I have a perspective, and we can talk a little bit about that too. But I want to give her one last word before she signs off.
Okay.
So what's next? First of all, as an epidemiologist, I'd be remiss if I didn't remind people that the pandemic is still very much going on. It may not feel that way here in the US, but absolutely critically is happening, in countries that have not been able to access vaccines in the same way the United States has. So it's still going to be a busy road ahead for people who are paying attention to this issue and looking at the data. That said, for me personally, and hopefully Beth agrees with this, I think our efforts in this has really exposed the inadequacy of our surveillance for these events, both domestically, but globally. The lack of standards that Beth talks about, the lack of ability to do more nuanced analyses of the data to answer really critical questions about who's being affected and how, and what we should be doing to stop these things, I think has really exposed severe vulnerabilities, and I think we need to help work to fix those things. And having spent so much time in the data, I think we have a better sense of some of the issues than maybe some of the other, thought leaders who have been, contributing to the conversation about what it means to be prepared for a pandemic.
Totally agree. And I think yes, and right, we are also looking at what are the other persistent public health crises that communities are experiencing. We know just having navigated this work that there is significant deficits in, like I said, the demographic data, especially. We did an analysis led by Sarah's team where we were able to determine that there are more than 1,000 different ways that state and local jurisdictions are depicting demographic categories across just COVID data. So imagine trying to actually, inform decision-making on vulnerable populations or populations that have been historically underserved. So there is a huge opportunity for us to explore that. I think we also are looking at, some of the comorbidities that became such an exacerbating part of the clinical role. Thank you, Jennifer. Here and the limited information. We, very early on, we got a lot of interest. Why aren't you putting out comorbidity data on as part of the dashboard? And the truth is the data is not available. It is 2 to 3 years old. It is not well maintained. It is not down to the sort of geographic granularity that would allow us to help let it inform some of these decisions. And so we made a very purposeful decision not to include it because of the deficits that were there. And so I think one of the things that we're turning our attention to is how do we think about the social determinants of health and the intersection of the social determinants of health with these larger data sets, and start to improve collection of that information at local and state levels where we knew it was possible. States have done something miraculous. They've been able to usher this data to us and through us for the last 18 months. So we know the capacity is there. How do we shape it into a broader effort instead of winding down these efforts, but expanding it to some of these areas where we just have very little insight into conditions and communities? And so I think that for me, I'm very excited about exploring what that looks like and how we can really empower state and local government to start taking more of a lead in doing this kind of surveillance work. I see in the chat we have some more questions, so I'm gonna go to the question here that says, "What do you think allowed you to develop the dashboard so fast?" I think a lot of it was governance, and maybe, I don't know, Mary, if you want to talk a little bit about governance and the fact that we were able to very quickly just say how the data would move, and talk a little bit about that.
Certainly. So the speed at which the dashboards were initially developed was primarily due to, I think, two things. One is that we, within the School of Engineering and within the Centers for Civic Impact, had an awareness of the tools and suites of tools that were available that would allow us to convert data into visualizations quickly and efficiently without a lot of bandwidth required by various web hosting services, because the volume of the hits that we were receiving for this data necessitated not having super complicated, expensive in terms of bandwidth visualizations. But then, as far as the governance aspect goes, we also have a collection of experts who understand how governments currently store and report out those data and which are reliable. So we didn't need to dig into a lot of research initially as to where to go to get some of these data. We did find that there were missing data, as Beth indicated, but additionally, the project leadership had a very clear-eyed view of the types of things that were important. And with that robust and specific prioritization, it was easy to get our resources devoted to the things that were most important for the public consumption. So that really, I think, having that clarity of vision around what we wanted to produce and what our lens was, what the stories we wanted to tell were, coupled with the expertise about where to go to get the data and which tools to use, allowed us to efficiently and quickly put visualizations on the board. There were visualizations that we have that required a longer tail because the data didn't exist in any sort of unified way. As Beth was describing, the demographic data, vaccine data is the latest set that has been published with some degree of regularity, and that the vaccine data has proven to be more of the same, which is another thing that we talk about a lot within the project, is that it feels a little like Groundhog Day, that the data providers repeat the same sorts of things that we have seen earlier in the pandemic. And so we advocate against that and sort of learning some lessons along the way and how to homogenize the data. But that initially, like I said, the clarity of view, the clarity of prioritization, and the subject matter expertise around where to go to get data and which tools would be best to use really helped us launch quickly.
Thank you, Mary. The next question is really, I think, for Mark, which is, how do you think that we're going to be including this work, or this canon of our work, in the development of our healthcare administration programs? And where do you see opportunities from a curricular perspective, I think, for this work as we move into a post-pandemic era?
Yeah, that's a great question. I think, it's interesting as we look back over our program's 30 some odd years, we have continually involved our curriculum around healthcare administration, given the context, the situation within which, we operate. And, I think back to 4 or 5 years ago, we developed a population health management program in response to the fact that everybody was starting to talk about this notion of population health, and people were actually in roles with population health titles, but really didn't have any firm understanding of sort of the evidence, what was the science behind these things. And so we stepped forward as a program. There were few in the country at that point to develop the curriculum to help people to understand what population health management really was, put some definition behind it. I see the same thing now in the last several years around health administration and people talking about data science, artificial intelligence, being able to use big data and data visualization tools. We've been using Tableau for many years in our program, teaching our students how best to accumulate and present data to improve their decision-making process. And I think going forward, what we've done just recently is added a population health informatics program course to our curriculum, again, to help provide some science, some evidence behind these notions about big data and how we can use big data to better manage our populations, not only our attributed populations, those patients within our health systems, but the broader population, the communities within which our organizations reside and for whom we provide service. So I think the work that you all have done has really helped to bring some clarity to how data can actually be used to manage and make decisions, inform policy, as you said many times, and really drive our organizations forward to respond to the needs of our communities.
Yeah, absolutely agree. I think, it's one of the most viewed visualizations that we have is a tracker that showed public policy making. So the states were making all kinds of granular calls, whether it was incremental economic calls about what's open, the types of businesses open, capacity decisions, and we plotted that against the growth of the disease in the background. And you can really see this direct connection between public policy and public health in this visualization, such a crisp way. And I think that there's probably a lot of different visualizations in the same canon that could be brought to bear as we start to think about these intersections of policy and outcomes in our communities. So absolutely. Sarah, next question is for you, and it's about tools. What are the visualization tools that we have relied on, which have changed since we started? So can you take us through a little bit around the tech backside and what the back end of the work and really understanding what tools were used?
Sure. So for data visualization, the maps are created using operational dashboard from Esri. The reason why we went for Esri is that it's basically the only service that right now it supports the amount of calls that these maps receive every day. And we are speaking about billions of calls. Actually, one funny fact is that at the beginning, when we partnered with Esri for the world map, they were a bit hesitant about the number of calls that this map was going to get. And it ended up beating any other dashboard that Esri had, beating even the Pokemon Go dashboard, which I think is an achievement. For the graphs on the CRC, the rest of the site, we started using kind of a wrap up around JavaScript data visualization, which is Plotly. And you can use it with Python, which was very convenient because all the data preparation for the visuals is also done using Python. And then we slowly shift into D3, which is a library, JavaScript library specific for data visualization, which allows us to integrate the visuals more into the site.
And in addition to that, we are also, looking at the sort of front end experience. So even throughout the process of hosting the entire site, we went through a very user-centered design process that really allowed us to think about what was the experience of the site, and we really were refining that front end experience from the perspective of the work. So thank you so much for your very thoughtful questions. Thanks to the panel, and obviously thanks to CAHME for having us today. It's been a thrill to partner with you on this session. I enjoyed it very much, so thank you. And I'm going to turn it back over to Melissa to wrap us up. Thank you for watching today's webinar in our CMC series. For more information or to view past webinars, slides, or to register for upcoming webinars, please go to www.cahme.org/CMC. Thank you.